I think this is one of these inflection points because it's such a different way of approaching therapy and drug development that a lot of the rules we used to apply, the randomized controlled clinical trial to compare immunotherapy to standard of care cytotoxic therapy, I just wonder if we aren't poised to actually start asking these questions a little differently along the lines that I just mentioned. Roy, you've thought about this more than just about anybody I know.
No, I would agree, and I like the idea of moving it to the front line with some selection, with moving patients off if they don't benefit. But you have to even wonder if we're using the right endpoints. So, we talk about median survival in clinical trials versus chemotherapy. Mm-hmm. Since we know that there's going to be a large proportion that don't benefit, the median might not change very much. What we might want to look at are 1 year or 2 year landmark analyses, but that then behooves us, we've got to have a marker, because we have to be able to identify up front which patients are going to benefit. But clearly we have populations of patients, the updated data at this meeting have shown us that even from the most refractory populations of patients that were treated in the early nivolumab trials, now almost 3 years out, there's this large fraction of patients still surviving, doing well. Many of them, by the way, not even getting the drug anymore, so they stop the drug.
See, that's why I'm pushing back on you guys on this, because to me, even if somebody has an EGFR TK mutant tumor, where there's a reasonably good chance that they're going to have a good response and it's going to last for a little bit of time, why wouldn't you think about a trial design where you actually started with the immunotherapy, and if they were not benefiting, you still have time to use the TK?
Yeah, we've thought about that, because even at this ASCO in lung cancer, 2 or actually 3, but 2 really good next generation EGFR TKIs, the AZD9291 and the drug from Clovis, both now work in T790M mutant resistant EGFR disease, and they're actually even more specific because they're specific only for the mutant tyrosine kinase, for the most part, a little bit of difference between the two. But the point is, within a year, patients will become resistant to those. The tumor, but the immune therapy will adapt and will have memory. So I agree, we need to think about how to sequence these together. Now, my feeling is that I've seen such good responses, having worked with this for years, as has Mark. If I had someone who had an EGFR mutation, I still would start, since they have a known driver, I would start with a TKI. But I'd try to get the immunotherapy going pretty soon, because I want to be ready for resistance.
You're not quite there yet, are you? We immunotherapy guys, we want to go faster.
But what about this idea in lung cancer of maintenance, switching 4 to 6 cycles of chemotherapy, and then instead of maintaining with cytotoxic or Avastin, maintaining with a PD-1, PD-L1. Have we moved past that, or is that an option that would be better embraced by community?
Well, I think that's I think all of those are being considered in terms of this. I do think that maintenance is well entrenched, but I do think our current maintenance agents are not perfect. I think a thoughtful approach would be perhaps if you induce a response, maintaining it with immunotherapeutics makes perfect sense. You can certainly design a trial to address this. Getting back to the EGFR mutant, I kind of agree with Roy, when you've treated enough EGFR mutants that have great responses that sometimes are durable for several years. The question is, maybe integrating immunotherapy at the time of initial progression. We all see these patients that kind of slowly progress, and we have to intervene at some point. There's lots of different ways to do this. I think we need to realize that we don't have unlimited resources in terms of patients or drug or finances, and we have to kind of figure out what are the really thoughtful questions that will advance the care of patients with this disease. I want to ask Roy a question. I want Roy to put his future vision on and predict. We have 2 completed trials in the second line, unselected patients. How do you think those trials are going to read out initially?
Well, the thing I don't like is when you do a randomized trial and you don't have a full grasp of the biology, and you don't know the selection factors for who's going to benefit and who's not, then you're gambling. And of course, if I were to have designed those trials, I would have wanted to know the population with a biomarker. Now the problem is no one knew that,
and nobody really knows it even now.
And no one could do that. But I think back to the early trials with erlotinib and gefitinib, where we didn't know the biomarker, we knew some clinical characteristics, and there was one positive trial and one negative trial because of populations that were studied and smoking, which now we can explain. So I can't feel 100% confident that those will be positive. As excited I am about PD-1 antibody therapy, depending on the population, and I don't know what biomarkers have been inserted within the trial, but not having prospectively looked at biomarkers, I think that I'm hopeful it'll be positive, but I would say there's a chance it could be negative. It's not a certain thing.
Yeah, and that my feeling is I'm preparing myself that they're going to be negative. But the point I was trying to make is that I don't think that should quell any enthusiasm for this class of drugs. And I don't want the message, if that does happen, let's face it, Roy, most phase 3 trials in lung cancer end up being negative. Right.
But I'll say that there's absolutely no doubt in my mind that these agents are drugs in lung cancer and will be approved somehow.
Yes, yeah, I
and look, even
agree with
ipilimumab
that.
had a little issues, early on, and tremelimumab.
Yeah.
So these agents are complicated. But will this strategy be the one? Maybe, maybe not. Will the PD-L1 biomarker be the best biomarker? Maybe, maybe not. What's going to happen is one of these agents will get approved, whether it be melanoma or lung, and then there'll be a big expanded access program.
Right.
And remember, that's where the EGFR mutations came out.
Yeah, exactly.
And the expanded access program, and people will treat, and centers like ours that have spores and other large NCI grants will start to do sequencing, we'll start to look at RNA expression profiles, and we'll find even better biomarkers.
Yeah, but I guess my point is that if they happen to be negative, then again, at least in our disease, I don't think that should quell any level of enthusiasm for the potential of these drugs.
Oh, I think these trials, even if you think that they're going to be negative, are going to give us so much information about biomarkers and have so much tissue and blood that if in the near future we find a biomarker, we can go back and query these subsets. The ipilimumab experience was wonderful. First therapy in a randomized setting to show survival advantage, but ultimately difficult to have accrued all of these patients and not to be able to go back and query and to find a biomarker for that drug. And all of these trials accruing now will allow us to do that even in retrospect.
So I think the trials are going to